All right, today Maggie, Mangino, and myself are going to talk about incretin injections for obesity. As of disclosures, myself and Maggie have no financial interest to disclose or conflicts of interest regarding any information presented. Our objectives today are to define obesity as a disease, address stigma associated with obesity, the pathophysiology, lifestyle modifications, pharmacological therapy, and additional benefits of incretin injections. So obesity, is it a disease? In June of 2013, AMA voted to recognize obesity as a disease requiring treatment and prevention efforts. This was justified because the AMA definition of the disease states an impairment of normal functioning of some aspect of the body, which with obesity, we see appetite dysregulation, abnormal energy balance, and endocrine dysfunction. It also has to have characteristic signs and symptoms. This could be like for obesity, increased body fat, which can cause joint pain, altered metabolism, and sleep apnea. Also, it has to show harm and morbidity. We see obesity correlated with type 2 diabetes, cardiovascular disease, and cancer. There are actually 13 known cancers related to obesity. We also see infertility, metabolic dysfunction associated steatohepatitis, or also known as MASH, dyslipidemia, and increased mortality. One study did show men with obesity under the age of 35 have shown to have an 8-year life reduction. All right, stigma. So a stigma is a negative ideology associated with excess body weight. This can cause adverse physical and psychological outcomes. Bullying can occur. Weight shaming is a form of bullying. It really doesn't help support weight loss. Biases are attitudes and ideas that affect our understanding, actions, or decisions. They typically arise as a response to a perceived threat. You can have implicit, which is unconscious, or explicit bias, which is conscious. A study published in 2019 showed that implicit attitudes towards body weight has not improved from 2007 to 2016. This is pretty big because it did show we have an overall improved implicit bias towards sexual orientation, race, and skin tone. Another study showed physicians spent 28% less time with patients with obesity versus patients with normal weight. This could be attributed due to thoughts of laziness, lack of discipline, and willpower. It is important as a prescriber of the incretin injections to understand obesity stigma and bias to provide exceptional care. Okay, so to be fully transparent, I am sure some of my own implicit biases will come out during this PowerPoint. I do point this out because it is impossible to completely eradicate all implicit biases. They are unconscious. So if you are a prescriber, I encourage you, love yourself through this journey of learning about your biases and diving into ways you can rise above them. If you would have asked me about the incretin drugs 2 years ago, I veered more towards my own explicit biases that people need to work harder to lose weight. It took me a good hard look in the mirror to realize I needed to do better for my own personal health goals as well as my patients. It is a work in progress. So what can you do? One thing is examine your own implicit and explicit biases. You can do the implicit association test. It's a tool developed by Harvard researchers that you can do online over a specific topic, such as body weight. Also, educate yourself on how weight impacts health. There's a ton of information online. The Obesity Coalition, Novo Nordisk, the Forward curriculum, and the Lilly website all have education on the incretin injections and obesity. I also signed up to receive a lot of articles on Medscape regarding obesity and the incretin injections. There's a lot of books on health, longevity, nutrition, and behavioral change that can also support your practice and your patient's understanding. Always show respect and stay curious. It's okay not to be an expert. Sometimes I learn a great deal from just listening to my patients. Avoid making assumptions I saw my colleague's patient a couple weeks ago, and the patient's weight was brought up as a risk factor for the conditions he was being seen for. I started discussing lifestyle measures with him, and he stopped me and says, actually, I'm in a good place. In the past 2 years, I've lost over 100 pounds. I had made the assumption that we were starting from scratch when in actuality, he was on his path and doing phenomenal. So ask your patients to share their experience with stigma. This will help you gain empathy and for your patients and facilitate them meeting them where they are at and learning about their sensitive topics. Encourage your patients to use self-talk. 5 positive affirmations can be great. Just have them write it down, put it on a sticky note on their mirror, and have them look themselves in the eyes and say it every single day. 80% of our thoughts are negative and 95% are repetitive. Our brain seems to be working against us. So it's imperative to lift up our patients and provide positive feedback during their visits. Be their biggest supporter when they're in the exam room. As for social support, it's pretty key to have, to be successful with their healthcare journey. If they're surrounded by people that are not comfortable with where they're at with their journey, it can be devastating. So finding social support and spending time with others that are uplifting is essential. I'm a big believer in training the brain to work for us versus against us. So jumping into the pathophysiology of obesity, let's talk about energy intake versus usage. Food gives us energy. The energy we get from food is converted into ATP, which is adenosine triphosphate. That's the energy currency of the cell. This occurs through a complex process involving digestion, absorption, and cellular respiration. Remember the Krebs cycle? That's part of this. We utilize nutrient resources from macronutrients, carbs, proteins, fats, along with the role of oxygen to get fuel for our body to work. So let's switch over to expenditure. This is how we utilize that fuel. 30% is from physical activity. That is either exercise or NEAT. NEAT is non-exercise activity thermogenesis. So think about just walking into a building, sitting versus standing. So your daily activities throughout the day. 10% is thermic effect. This is how food is broken down in the body. And 60% is our resting metabolic rate. Our liver and brain use the most energy while our body is at rest. The brain itself uses 20% of our total body energy at rest. Furthering patho of obesity, we will address the dysregulation of body weight in people holding on to excess weight. So physiological factors include hormone dysfunction, think like hypothyroidism, elevated cortisol levels, and insulin resistance. Genetic factors are often polygenic, involving multiple genes. Those genes can influence hormone regulation of leptin, the satiety hormone, and ghrelin, a hunger hormone. Genes can influence fat storage and metabolism, such as the FTO gene. The FTO genes may have a higher tendency to store fat and a less ability to feel full. Genes can also influence your basal metabolic rate. And a huge field that is growing is the idea of epigenetics, which is the environmental factors such as food intake, physical activity, and prenatal conditions, just to name a few, influence how genes are expressed. Changes in gene expression can turn genes on and off, affecting various pathways in the body. A huge aspect of epigenetics is ACEs, so adverse childhood events, which are strongly linked towards obesity. When a child experiences a trauma such as neglect, abuse, family dysfunction, chronic stress does occur, leading to overactivation of the body's stress response system, raises cortisol, which promotes fat storage. Environmental factors contributing to obesity are what we commonly correlate obesity with. Things we can control, think sedentary lifestyle, ultra-processed high-calorie foods. But other environmental factors include food deserts, which are areas where healthy food options are limited, economic constraints, and living in an area that lacks access to safe parks, sidewalks, bicycling transportation, and recreational facilities. Moving to endocrine disruptors. These are chemicals that interfere with the proper functioning of the endocrine system. Examples include plastics such as BPA, plasticides, phthalates, parabens, and PFAS. Phthalates are used to make plastics more flexible and harder to break. That can be found in food packaging, cosmetics, fragrant products, flooring, paints, fiberglass. detergents, just to name a few. Parabens you typically see in cosmetics, pharmaceuticals, and food products. PFAS are those forever chemicals often used to make items water and grease resistant. These EDCs can increase the number and size of fat cells, glucose metabolism, and exposure have effects that span generations. So the primary person being exposed, it also affects their offspring. Finally, the gut microbiota, which has gotten a lot more research in the past decade. A diverse gut microbiome is strongly correlated with a healthier body weight. High-fat foods and antibiotic usage both play a role in causing an imbalance in the microbiota. Okay, so there is a lot going into the patho of obesity, but on this slide, we're going to specifically address the appetite regulation via the brain because the incretin injections specifically address this aspect of the pathophys. So hormones that we think of 3 different types of eating habits: homeostatic, hedonic, and then the executive function. For homeostatic eating, think eating for hunger. We have satiety hormones such as GLP1, GIP, and leptin, plus more. Those make us feel full. The hormone that drives hunger is ghrelin. It is quite intense and very hard. I'm going to move this so you can read those. Very hard to overcome. These hormones are dysregulated in patients with excess weight. When they start taking incretin injections, it is amazing the positive effect they have with actually feeling the sensation of being full and the reduction of constant hunger. Oftentimes, before taking the drugs, they're not even aware of this dysregulation that's occurring. Another aspect of hunger is hedonic eating, which is eating for pleasure. Dopamine, opioid, and cannabinoid receptors are the focus here. Examples include going out to eat for pleasure or celebrating a good day with food. Typically, we do this with ultra-processed foods, and it really doesn't matter if we're hungry or not. Finally, we have the executive functioning, which is deciding to eat. People with excess weight may make decisions to choose immediate gratification over the long-term health benefits. Examples could include, I need to have a soda with each meal so I get that energy and prevent a headache. And what we have to acknowledge is that our thoughts create feelings. Those feelings turn into behaviors, and that can provide temporary relief. But this cycle can be harmful if we're acting based on thoughts that are not healthy and beneficial to us. So moving on to lifestyle modifications that we do in conjunction with the incretin injections. We're going to talk a little bit about nutrition. So the key thing here, you have to tailor this to the individual. But over time, you still work towards optimal goals of health and wellness, but everyone's going to start on a different page. So first, fiber. Men need at least 35 grams of fiber per day, women at least 25 grams. I typically think predominantly of fruits and vegetables here. So recommended for adults, you need to have at least 5 vegetables and fruit per day. And also, if you remember thermogenesis, fiber-rich foods take more energy to break down, so it can help with that energy expenditure. And I want to address that carbs are really not the problem as a whole. Fiber comes from complex carbs, and we want to promote this for all patients, as the studies do show that fiber lowers ghrelin and promotes a healthier gut microbiome. However, simple carbs, that's a totally different story, and those are the carbs we want to limit. But classifying all carbs are bad, not a great stance to go by. Those simple carbs to steer clear from are ultra-processed foods, or UPFs. The UPFs are truly a major issue in the standard American diet. Think of like foods high in salt, sugar, and fat. A study in 2019 by Aaron Hall showed that we eat 500 more calories per day on a diet high in ultra-processed foods versus a diet low in UPFs. It's likely due to UPFs being not nutrient dense, therefore, like, our bodies can consume more before we feel that feeling of fullness. Plus, if you remember, fiber lowers the ghrelin, so that's also a reason UPFs are not fiber-rich foods. Also, if you think about hedonic eating, UPFs can really help can show that dopamine being activated every time we consume them if you're having positive thoughts on the food that you see in front of you. So it's important to kind of address that with patients by saying, okay, those incretin injections are going to help you with your eating habits, but when you see the bad, like the unhealthy UPFs, you want to have those like thoughts of, this is going to make me feel bloated in a couple hours. I'm going to have like my energy is going to drop. And then when you visually see the fiber rich foods, such as the picture on the screen, you think, wow, that's going to heal my body. My gut's going to like this. The bacteria in my gut is going to be able to break this down, and I'm going to feel more balanced as a whole. Next is water. This is where some of my explicit bias may come in. I've really tried hard to eliminate all beverages besides water, black coffee, and herbal teas from my patients' intake. I explain diet drinks are no better for the body. There's actually a study that shows women that drink more than 2 diet drinks a day have a higher risk of cancer as well. There's no benefit, but there is a lot of negative to drinking our calories. I'm not sure if you know, but Mountain Dew and Gatorade that is made in the US is banned in Europe. When you start hearing things like this, that some of the typical food and drinks here in America are banned elsewhere, try to take a second look at that and think, wow, maybe we need to be looking at things a little differently. Last, protein. A lot of hype on protein regarding weight loss, as it is the building block of our bodies. The main time I really focus on protein are with my patients that are able to strength train. Studies do show patients who strength train, so it's lifting weights, need to consume 30 grams of protein within an hour or two of lifting to promote muscle synthesis. You cannot build muscle unless you lift weights in conjunction with that amount of protein. Not sure we've done a great job by focusing so much on protein when it comes to weight loss. And that's because if you push protein and you're on these weight loss injections, which are causing you to be in a calorie deficit, you don't really have the desire to be eating all the fiber that is essential for longevity. And that's what we want to focus on with our patients. Yes, we want to lose weight, but the main goal is to create a very healthy longevity life, and plant-based eating is more focused towards that. And I've definitely been a prescriber of trying to put people on high protein, but the more I research and realize that really the best thing you can do is just eating a healthy, balanced diet. So in summary, real food is always best. All right, last thing on my slides is movement. So how do you encourage patients to increase their activity? You want to focus on patient-specific goals. Not everyone's at a different level of what they're able to do and what they're not able to do. So try to keep it patient-specific. And mind language, some people really don't like the word exercise. It's triggering for them. So in those patients, I try to use words like just increasing movement or physical activity, and prescribing activity. Like that is imperative. Like we prescribe drugs, we also need to be prescribing lifestyle measures and specifying it to the patient. I use a lot of 3D planning for patients, and that includes being directional, doable, and detailed. They need to write out, so whether it's movement or nutrition, write out a plan that's encompassing of 3D planning and review it every day, and that can help with success. You want to connect them to their interests. Maybe it's increasing time with grandkids, running a 5K, and focus on the benefits other than weight loss. It's not just about weight loss here. When they lose weight, it improves the cardiovascular system, improves mental health, reduces the risk of injury. And my patients love when I'm like, hey, we work on our weight loss and we can get off other medicines. And I get a lot of buy-in that way. And it's exciting. And I like it too, because the less meds we have to manage, the more you can focus on the things that patients can do and have that sense of control. On the other side of this slide talks about like the American Heart Association recommendations. So these are like the ultimate goal. Not everyone's going to hit there, but it is in the back of your head, something you want to think about of like getting people solely to this point of aerobic exercise, which is at least 150 minutes a week of moderate intensity or 75 minutes a week of vigorous intensity, or a combination of both spread throughout the week. As well as strength training at least 2 days a week, total body, 30-minute sessions at minimum. Make sure you pair that with that 30 grams of protein within the first 1 to 2 hours, and then reducing sedentary time, which I liked seeing that on there. And it talks about just we sit so much in our society, and how can you increase your standing? Could you get a stand-up desk? Could you just walk around once an hour in your office or wherever you're at? Okay, I am going to switch it over to Maggie and stop sharing my screen. All right, Maggie, take it away.
Okay, and Emily, can you see my screen okay? All right. Okay, well, thank you, Emily. And I'm going to focus our next section a little bit more detail on the incretin mimetics, starting with a drug class review. And then we'll do a review of weight loss outcomes from clinical trials, and then dosing recommendations and evaluating for efficacy. So the two drug classes we'll talk about are the glucagon-like peptide receptor agonist, or GLP1s, and the glucose-dependent insulinotropic polypeptide, or GIP, and GLP-1 combination receptor agonist. So I'm just going to use the abbreviations of those throughout the rest of the presentation. And as Emily just reviewed, we know that diet, exercise, and behavioral interventions are the mainstay of treatment for patients who are overweight or obese. However, if lifestyle changes aren't adequate enough to, result in clinically significant weight loss, pharmacotherapy and/or metabolic and bariatric surgery may be appropriate. Most guidelines recommend pharmacotherapy for patients with a BMI of 30 or greater, or 27 or greater with a weight-related comorbidity, such as diabetes, hypertension, hyperlipidemia, obstructive sleep apnea, etc. So this presentation focuses on the incretin mimetics. So I'm not going to spend much time talking about other medications for weight loss, but I did just want to provide a broad overview of the currently available FDA-approved medications for both short-term and long-term weight management. So historically, stimulants such as phentermine and diethylpropion which have been around for over 40 years, have been used for weight loss. These work by suppressing appetite, but they do have some limitations in that they can only be used short term. So usually this is recommended to be about no longer than 12 weeks. And patients can develop tolerance to the anorectic effect. They also have side effects like increased blood pressure and tachycardia, which can certainly limit it in a lot of our patient populations. And then as far as long-term treatment, there are several currently FDA-approved medications for long-term management of weight loss, which include the GLP-1 agonist, liraglutide and semaglutide, and the GIP/GLP-1 agonist, tirzepatide, and then orlistat, as well as combinations of other medications, such as the phentermine with topiramate extended release and naltrexone with bupropion extended release, are also approved for long-term use. So I wanted to start with a drug class overview and highlight which agents have the FDA approval for chronic weight management versus those with just type 2 that have the indication for type 2 diabetes. So you can see bolded that liraglutide as brand name Saxenda and semaglutide as brand name Wegovy, and then tirzepatide as brand name Zepbound have the FDA indication for chronic weight management. I have included all of the GLP-1 agonists on this table for reference because while some are only indicated for type 2 diabetes, we know that patients with type 2 diabetes often have obesity as a comorbid condition, and we have a lot of data on weight loss with these medications for people with type 2 diabetes. The mechanism of action of GLP-1 agonists responsible for blood glucose lowering are the same for which these agents cause weight loss. So the glucose-dependent insulin secretion from pancreatic beta cells reduces hyperinsulinemia, which mitigates the weight gaining effect of insulin. And then within the CNS, GLP-1 receptors activate vagal afferent neurons, which delays gastric emptying and promotes satiety. And additionally, the GLP-1 activity in the brainstem and hypothalamus further suppress appetite. So this appetite suppression, the delayed gastric emptying, and the early satiety lead to reduction in calorie intake, which ultimately leads to reduction in weight. And although the mechanism of weight loss is similar among the medications in this class, the magnitude of effect varies. So the American Diabetes Association breaks these down into those with very high efficacy for weight loss, which includes semaglutide and tirzepatide, and those with high efficacy for weight loss being liraglutide and dulaglutide. And that's all based on results from outcomes data. These are subcutaneous injections administered either daily or weekly, with the exception of semaglutide, which has an oral and subcutaneous formulation. If patients are already on insulin, or if they're already on a secretagogue, like a sulfonylurea, dose reduction of those agents may be necessary when starting a GLP-1 or a GIP-GLP-1 combination to reduce the risk of hypoglycemia. So just something to be aware of if patients are already on those drugs at baseline and you're initiating one of these. And another important consideration is that due to the lack of additive glycemic benefit and potential theoretical increased risk of side effect, these are not recommended to be used concomitantly with DPP-4 inhibitors. So if they're on one for baseline, we recommend discontinuing that if you're initiating a GLP-1. These are contraindicated in anyone with a personal or family history of medullary thyroid cancer, and they should be avoided in patients with a history of pancreatitis. Also, due to the nature of the mechanism of action causing slowed gastric emptying, these agents should be used cautiously in patients with gastroparesis, or potentially even avoided altogether if they have severe symptoms of gastroparesis, or if we're having to use multiple more medications to manage the side effects or manage the issues that come along with gastroparesis. It may just be a good idea to avoid this class of medications. The most common side effects are GI related, so nausea, vomiting, diarrhea, constipation, abdominal cramping. But these are usually dose related and often do improve over time. So that's why these all start with a very low dose and have slow titration schedules, which we'll talk about in a little bit more detail in a minute. There is also the caution with the subcutaneous semaglutide and the potential for worsening retinopathy. This comes from the SUSTAIN 6 trial where they saw higher rates of retinopathy complications compared to placebo, but the effect was reported to be mainly observed in patients with pre-existing diabetic retinopathy. So just something to be aware of, particularly if they had that as an underlying condition. And in clinical trials of GLP-1 agonists, they overall show that GI side effects generally do develop in 40 to 70% of treated patients, although they've been reported in up to 85% of people prescribed these medications. So, and this is across all GLP-1 agonists, including those with longer and shorter half-lives and in both subcutaneous and oral formulations. So while the incidence of the GI side effects is fairly high for most people, these side effects are mild to moderate in intensity and are transient. This is where some good initial counseling on non-pharmacologic strategies can play a big role. So we know that strategies related to eating and lifestyle habits can decrease the occurrence and severity of GI side effects. So things such as eating slowly, eating smaller, more frequent meals, avoiding lying down after a meal, or stopping once you reach that feeling of fullness are all strategies that patients can be counseled on to help decrease the GI side effects. And additionally, what you eat can make a big difference. So patients could be counseled to avoid greasy or high-fat foods, meals high in sweets, spicy foods, and then, of course, to lifestyle changes, such as doing light exercise or maybe even keeping a food diary so patients can help identify for themselves like which foods may be more likely to trigger their GI side effects and minimize those. Can all be strategies to help decrease those adverse effects. But if they do occur, we can do things like slowing the planned dose increases or extending the current dosing, by 2 to 4 more weeks or even longer before up titrating the dose again. We can even potentially suspend treatment temporarily until symptoms resolve, but then resume at a lower dose for those who want to remain on the medication. So on the next few slides, I'm going to review some of the weight loss outcomes of the incretin mimetics from clinical trials. So many of the initial studies of GLP-1 agonists that were done in people with type 2 diabetes, weight loss was assessed as secondary outcomes. So this table summarizes weight loss outcomes in randomized controlled trials with GLP-1 receptor agonists compared to placebo or metformin. Of course, this does not include all of the studies, but I just wanted to highlight a few. So starting with the LEAD-2 study, which goes as far back as 2009, it looked at the addition of liraglutide to metformin and showed that body weight decreased in all liraglutide dose groups with statistical significance at the 1.2 and 1.8 milligram doses. So that's just shows that we have long-standing, going back as over a decade, showing secondary weight loss outcomes in a GLP-1. The next three on this slide, or on this table, are studies with semaglutide. So there are several studies from the SUSTAIN clinical development program looked at weight loss with subcutaneous semaglutide in patients with obesity and type 2 diabetes. And a dose-dependent weight reduction was seen across all BMI subgroups. So specifically in the SUSTAIN 1 trial, semaglutide at 0.5 milligrams and 1 milligram were compared to placebo, and both semaglutide doses showed statistically significant weight reduction compared to placebo. And then in the SUSTAIN Forte trial, which evaluated the expanded dosing of semaglutide up to 2 milligrams weekly, it further supported that dose-dependent weight reduction with a mean reduction in weight of 6.4 kilograms at that 40-week follow-up period, and showed that 59% of participants achieved weight loss of 5% or greater. And the Pioneer study looked at oral semaglutide and showed, again, similar outcomes with dose-dependent decreases in body weight. So it included the results of Pioneer 1, which was showed statistically significant weight reduction at the 7 and 14 milligram doses compared to placebo. And lastly, while dulaglutide does not have an FDA indication for chronic weight management, we know that it is often used to treat type 2 diabetes in individuals who may be overweight or obese. So I wanted to highlight some of the weight loss outcomes with this agent, which also showed dose-dependent decreases in weight. In the Award 11 trial, dulaglutide 4.5 milligrams was superior to the 1.5 milligram dose for weight loss at 36 weeks. And there was greater weight loss at the 3 milligram dose, but it was not statistically significant compared to the 1.5 milligram. So those were all studies looking at weight loss as secondary outcomes. So the three studies on this slide highlight some of the clinical trials that looked at weight loss as a primary outcome. So SCALE Diabetes looked at liraglutide in adults with type 2 diabetes with a BMI of 27 or higher, while SCALE Obesity looked at individuals with a BMI 27 or higher with hypertension or dyslipidemia, or those with a BMI greater than 30 or greater, but it excluded those with type 2 diabetes. And in both studies, the SCALE Diabetes and SCALE Obesity showed statistically significant reduction in weight at the liraglutide 3 milligram dose compared to placebo. And then lastly, on this slide, step 1 looked at semaglutide in adults without diabetes who had a BMI of 30 or greater or 27 or greater with a weight-related comorbidity, and showed a mean weight reduction of 15.3 kilograms or 14.9% of total body weight reduction in the semaglutide 2.4 milligram group. So similar to the previous couple slides, I'm now going to wanted to share the weight loss outcomes of tirzepatide, which is at this point our only combination GLP-1 receptor agonist. So starting first with the studies in patients with type 2 diabetes, which assess weight loss as secondary outcomes. The SURPASS clinical trials include several phase 3 trials evaluating efficacy and safety of tirzepatide at the 5, 10, and 15 milligram doses compared to placebo, or in some of the SURPASS trials compared to active comparators, one including semaglutide, which is included in the SURPASS 2 trial. Others looked at tirzepatide compared to basal insulin, but all in patients with type 2 diabetes. So in SURPASS 1, they showed significant weight reduction in the tirzepatide groups at all doses compared to placebo. And you can see on there the weight reduction at each of those doses with a 9.5 kilogram reduction in the 15 milligram dose. And then in SURPASS 2, this actually looked at tirzepatide versus semaglutide 1 milligram and showed statistically significant greater weight reduction in the tirzepatide group at all doses compared to the semaglutide 1 milligram, with a mean weight reduction of 11.2 kilograms in the tirzepatide 15 milligram dose versus 5.7 kilograms in the semaglutide 1 milligram dose, which the 15 milligram dose is the maximum dose of tirzepatide, while 1 milligram is not the maximum dose of semaglutide, but that's what was studied in this particular trial. And then the SURMOUNT clinical trial program evaluated efficacy and safety of tirzepatide as adjunct to lifestyle intervention compared with placebo on chronic weight management. in adults with a BMI 27 or higher without diabetes, as in the SURMOUNT-1 trial, and with type 2 diabetes in the SURMOUNT-2 trial. So these were both phase 3 double-blind randomized controlled trials with co-primary endpoints of the percentage of change in weight from baseline, and then also they looked at a weight reduction of at least 5% or more. So in SURMOUNT-1, about 2,500 adults with a mean baseline BMI of 38 were randomized to receive once weekly tirzepatide at 5, 10, or 15 milligram weekly doses, or placebo for 72 weeks, and this did include a 20-week dose escalation period. The mean percentage change in weight at 72 weeks was a 15% decrease at the 5 milligram dose, a 19.5% decrease at the 10 milligram dose, and a 20.9% weight decrease with the 15 milligram dose, showing like substantial and sustained reductions in body weight at all doses compared to placebo. And then SURMOUNT-2 showed a mean decrease in weight of 12.8% at the 10 milligram dose and 14.7% at the 15 milligram dose. So we did talk about SURPASS-2 trial, which looked at tirzepatide versus semaglutide in people with type 2 diabetes, where weight loss was a secondary outcome. But overall, there are very few large head-to-head active comparator trials for anti-obesity medications. Maybe one of the most noteworthy is the STEP8 trial, which compared semaglutide 2.4 milligrams versus liraglutide 3 milligrams in patients who were overweight or obese without diabetes. And this was a 68-week study. It included 338 patients that received either semaglutide 2.4 milligrams weekly, titrated over 16 weeks, or liraglutide 3 milligrams daily, titrated over 4 weeks, or a matched placebo to either of those two groups. And all participants received counseling every 4 to 6 weeks on diet and physical activity recommendations of 150 minutes per week of physical activity. If patients could not tolerate the semaglutide 2.4 milligram dose, they could dose reduce to 1.7 milligrams, and then additional attempts were made to increase back up to the 2.4 milligram dose. However, in the liraglutide group, if patients could not tolerate liraglutide 3 milligrams, treatment was discontinued, and then therapy was reinitiated with a second titration attempt according to prescribing information recommendations. So this was addressed by the authors as a study limitation, and that poor tolerance of the maintenance dose, how they handled the response to the poor tolerance of the maintenance dose differed in how they handled that between the two groups. And they did that because they wanted to adhere to approved prescribing information and guidelines, but this could have definitely led to more participants permanently discontinuing the liraglutide group after an adverse effect than the semaglutide group. And the gastrointestinal adverse effects were common, with over 80% of patients receiving one of the two GLP-1 receptor agonists experiencing these effects, with higher rates in those receiving the semaglutide. Rates of treatment discontinuation because of adverse effects were a lot lower, though, than the overall reported incidence of the effects. So treatment discontinuation in the liraglutide group, 11% of patients discontinued. In the semaglutide group, 7.9% of patients discontinued treatment, and then in placebo, 7.1% discontinued treatment. But overall, the overall conclusion was that among overweight or obese adults without diabetes, semaglutide once weekly resulted in significantly greater weight loss at 68 weeks compared to liraglutide, with a 15.8% weight reduction in the semaglutide group versus 6.4% in the liraglutide group. So historically, with many of our anti-obesity agents, we would often see weight loss of 4 to 5% from baseline, which is clinically significant. But with some of these newer agents, we're seeing weight loss over 15% from baseline, which is significant because we know that weight loss improves obesity-related complications. So at up to 5% weight loss, we can see improvements with blood pressure and blood glucose. At 5 to 10% weight loss, we can see improvements in cholesterol and in type 2 diabetes prevention. At 10 to 15% weight loss, we see improvements with obstructive sleep apnea, GERD, cardiovascular disease, osteoarthritis in the knees. And then at over 15%, we can see significant improvements with type 2 diabetes, even heart failure. So it is quite impactful to have these medications with these high levels of weight loss associated with them. So now that we've discussed some of the weight loss outcomes in clinical trials as either primary or secondary endpoints, I wanted to further break out the two GLP-1 agonist and the GIP GLP-1 agonist with FDA approval for chronic weight management to talk a little bit more about the recommended dosing and evaluation for efficacy. So starting first with the liraglutide, which as brand name Saxenda has the FDA approval for use in adults as adjunct to diet and exercise in patients with a BMI of greater than 30 or BMI of 30 or greater, or 27 or greater with at least one weight associated comorbidity. So this has the FDA approval for chronic weight management. It is recommended to start with the 0.6 milligram per day dosing for 1 week, and then you can increase by 0.6 milligrams per day at weekly intervals to the target of the 3 milligram once daily dosing. If patients are unable to tolerate an increased dose during that dose escalation period, you can consider delaying the dose escalation for an additional week or longer if necessary. And patients may continue on the maximum tolerated dose, even if that's less than the target of 3 milligrams per day, if weight loss is achieved on that dose. And after 12 weeks at the maximum tolerated dose, or at 16 weeks after the initiation of therapy, we should evaluate the change in body weight at that time, and medication is recommended that the medication be discontinued if at least 4 to 5% of baseline body weight loss has not been achieved. So this same medication is also FDA approved for children and adolescents age 12 and older with a body weight over 60 kilograms and with obesity. And of course, it's always as adjunct to strict lifestyle interventions. So the dosing is similar to adult dosing, and that you start with 0.6 milligrams once daily for a week and can increase as tolerated by 0.6 milligram per day increments at weekly intervals up to the target in the max dose of 3 milligrams. For this patient population, the manufacturer does recommend discontinuing if the patient cannot tolerate at least the 2.4 milligram dose. And if patients have not had at least a 1% or greater reduction in BMI from baseline after 12 weeks on the maintenance dose, then it's recommended that therapy discontinued, since the patient is unlikely to achieve meaningful and sustainable results with liraglutide. The next GLP-1 agonist with FDA approval for chronic weight management is semaglutide, as brand name Wegovy. So similarly to the liraglutide, the FDA has approved semaglutide for adults as adjunct to diet and exercise if patients have a BMI of 30 or greater, or 27 or greater with at least one weight-associated comorbidity. So the dosing for this starts at 0.25 milligrams per week times 4 weeks, and then it can be increased to 2.5 milligrams for 4 weeks, and then it can be increased every 4 weeks. So then the next step would be the 1 milligram, the 1.7, and then the 2.4. The manufacturer does recommend discontinuing therapy if patients cannot tolerate at least the 1.7 milligram dosage. However, many patients do achieve weight loss on a lower dose. And so I think generally speaking, some of the guidelines recommend that patients can continue on the maximally tolerated dose, even if it is less than that 1.7 milligram per week dose. It is recommended to evaluate the change in body weight after 3 months. And if patients have not achieved at least 5% of baseline body weight loss, it's recommended to discontinue the medication. And then this agent is also FDA approved for children aged 12 to 17 with an initial BMI in the 96th percentile or higher for age and sex. And as adjunct therapy with a reduced calorie diet and increased physical activity. So dosing is the same as adults, and similarly, the manufacturer does recommend discontinuing if the 1.7 milligram dose cannot be tolerated, the 1.7 or the 2.4 cannot be tolerated. However, there was a trial, the STEP Teens trial. In that particular trial, patients could continue on the maximum tolerated dose. So I think just make sure that you're like continually assessing for that change in BMI from baseline. And then the third agent with the FDA approval for chronic weight management from these classes that we're discussing is tirzepatide, as brand name Zepbound. Similarly to the previous two, FDA approved in adults as adjunct to diet and exercise with a BMI 30 or greater, or 27 and greater with a weight-related comorbidity. Dosing starts at 2.5 milligrams per week times 4 weeks, and then can increase to 5 milligrams. From there, it can be increased every 4 weeks by 2.5 milligram per week increments as needed up to the maximum dose of 15 milligrams per week. And the guidance of when to evaluate a change in weight from baseline to determine if therapy should be continued isn't as clear-cut with tirzepatide. Some suggest evaluating at 6 months and then discontinuing if at least 5% of baseline body weight loss has not been achieved. And as of now, this is not FDA approved for use in pediatric patients. The safety and efficacy data have not been established in pediatric patient population. There is an ongoing trial, the Surpass Peds, which is looking at tirzepatide in patients 10 to 17 with type 2 diabetes inadequately controlled with metformin, basal insulin, or both. But at this time, it's not approved for pediatric use. Okay, so now I'm going to turn it back over to Emily to discuss some of the published and ongoing studies for other chronic conditions, and she'll wrap up our presentation.
All right, so as Maggie has mentioned, incretin injections are not solely to use for helping patients lose excess weight. There are ongoing studies that have been published, and they have been published or still ongoing that show promise for MASH, dementia, cardiovascular disease, heart failure, sleep apnea, osteoarthritis of the knee, substance use disorder, specifically for smoking cessation, as well as alcohol use disorder. So I just want to have the takeaway of these drugs are just not for cosmetic benefit. We are helping people in the disease states across the spectrum of health. So we'll wrap it up. For patients with inadequate response to lifestyle changes, pharmacotherapy with GLP-1 or GLP-1 GIP agonists may be appropriate. So these are our email addresses, and we want to open it up for any questions.
Not seeing any questions in the chat just yet. I'll give it just a minute though. Just a reminder that there's a link for the evaluation for credit that is in the chat for everyone. When you exit the webinar, you'll see the Survey Monkey and you can click continue to do the evaluation for credit. This was a fantastic presentation. For patients who are seeking guidance on if they're on the fence on using one of these medications for clinical indications, if there may be someone who's not falling in the full category for the studies that you described, as well as some of the health risk factors, how do you guide that conversation in clinical practice, Emily?
So you're talking about patients that don't meet the BMI of 30 or greater, or 27 plus at least one comorbidity. I think you just encourage them, and you still have to figure out where did they land and how their lifestyle is affecting this. But also, like I said, with all of the components that correlate with the pathophysiology of obesity, and trying to just educate them on that and see where you can meet them on lifestyle measures. So whether it's, sometimes I'll give patients books to read if I have patients that like to self-educate, or each time I see them, give them like a little tidbit of information. That seems to help a lot. But always just letting them leave the visit feeling encouraged, like, okay, someone else believes in me, that I am capable of living a healthier life than I am today.
Perfect. I've heard you speak earlier about recommending protein and then shifting back to fiber. There's a question in the chat. Can you remind us how many grams of protein and fiber are recommended?
On fiber, it is recommended for 35 grams a day or more for men, and 25 grams a day for women. a caveat to that is like, when you think about that microbiome for your gut, if you have a patient that they grew up on like ultra processed foods and meat and potato diet, when you start incorporating that fiber in their diet, it's gonna be an adjustment. They don't have the bacteria in their gut to already break down and process those foods. So it is a good a time to be like, okay, I do want you to eat more of these. Here's the reason why, but you start slow. You can't just all of a sudden go from eating no fiber to eating 25 plus grams. And then it like leveling their expectations of, hey, you're going to feel a little bit more bloated. Your bowels are going to change a little bit on this. But at the end of the day, after like a month of adjustment and like a slow, steady incline, you start talking about the benefits other than weight loss of just like, you're reducing your risk of colorectal cancer, you're improving your heart health. You start talking about all those things so that way they can kind of rise above that discomfort maybe.
Right.
But also like they have associations, like some people just hate the idea of vegetables. So you have to slowly start adding that understanding and like excitement. Like I try to tell patients too, when you're like, for instance, a patient doesn't like vegetables, they find a vegetable that they'll eat. When they're actually eating the food, I have them think positive thoughts of like, I'm healing my body, I'm creating healthy bacteria in my gut, I'm reducing my risk of cancer. I feel really good about the energy I'm providing for my body, because when they actually think about positive and like gratification, that helps with that hedonic eating of just like the dopamine surge. And it can be very effective long term. It's
Yeah.
a long term gain. So that can be helpful of just positive mindset when they're making a positive choice. Now, when they're
Perfect.
choosing to eat the pizza, they eat the pizza. They
That's
don't hate themselves for it. They just move on. And then the next time they make a healthy choice, they like fixate and like do that mindfulness eating. In regards to protein, 30 grams is essential to consume within an hour or two after strength training. This helps build up your muscles in order to, because the more muscle mass you have, which with weight loss, you will always lose muscle mass, no matter if you're on these drugs or you're just losing weight. But in order to slow that down, but also over time improve that basal metabolic rate, you do need to build up muscle mass. And so the 30 grams of protein with the strength training are helpful. And then just like basic, like follow the RDA guidelines on like daily protein intake.
perfect. Once a patient has lost weight with these medications to their goal BMI, do you wean them off of the agent, or do you keep them on it lifelong?
So I've only had a few patients get fully to their BMI goal, and that's probably more on my end of like my biases of like really not diving into these until about a year and a half, 2 years ago. Because I really was like, oh, they're not working hard enough. So once I kind of got over that and we're like, wow, these drugs are really helpful for all the reasons we know. The ones that I have gotten, I keep them on the highest dose that they're able to tolerate. And then you can either, what I do is like, I'll either have them take them every 10 days, and I keep a very close eye on like, if your BMI gets under like 18 or below, then I will discontinue the med. And I had one patient who I inherited from another provider. She was on semaglutide and she ended up getting to a BMI of 17. Stopped the semaglutide, saw her back in a month. Her BMI was 18.2. And I saw her another month after that just to ensure that we're on a steady state. She did not have a history of an eating disorder. She just was in a calorie deficit and she was able to maintain. And so with her, I'm going to see her every 3 months for a year and just keep a close follow-up. And my patients, I always give them that open door of like, if you are concerned, like they're educated every visit, come and see me. Let's talk through this. But a lot of patients, like, when you're asking them to do all these lifestyle changes, this is not a short term, you're not going to fix it all in a year. This is like, I'm still working on myself. Everyone's still working on their health journey. So a lot of times when you're adjusting those hormones and regulating those hormones to help them get in a healthy weight, they may need to be on them for years. So I always talk to my patients about, hey, just remember, this is a marathon, not a sprint.
That's right. Can these medications affect your thyroid levels? Or Maggie, did you want to weigh in on that as well?
Yeah, I mean, just to add, I think that I do think this is a highly discussed topic as far as like, what do you do when they do finally lose weight? How do you handle those patients? Because the studies that have looked at that so far have shown that the majority of people do regain the weight when they stop the medications, and that's why these are approved for long-term use. But I think it's also still really early on to be able to like make that blanket statement that you would keep people on the medications. I think it's very like individualized, like what Emily said too. I think just kind of anecdotally from patients I have worked with, some of what I see is, you know, patients who are at a very high weight when they start the medications aren't really able to do much physical activity. They then lose weight and are able to become more active. They no longer have knee pain and back pain. So they're so much more active. And so I think they're able to sustain some of those lifestyle changes. And so I think by either decreasing the dose and sort of slowly titrating off, those people have been able to maintain their weight loss. But I don't think we have any like large studies that show that yet. But I definitely think there will be a lot more, hopefully there will be a lot more guidance, you know, coming out about that in the coming years as we, you know, look a little bit more about what to do. How do you get people off these medications? Can you get people off these medications?
There's 2 more questions in the chat, and they're both from Michelle. Can these medications affect your thyroid level? It's the first one.
To my knowledge, I don't think I have read anything that talks about the impact of impacting thyroid levels with this class. Emily, do you know of anything?
It's not, you don't have to draw a TSH beforehand, if that's what you're talking about with thyroid levels. Because that won't associate with that thyroid medullary carcinoma, which I had an endocrinologist once tell me, like that type of cancer is extremely rare, even in the endocrinology realm where they're going to see it more. So it's not a very common, I've like never had to have it be a contraindication to start a patient.
Okay. What's your recommendation to a diabetic if their A1C drops below 5?
Great job, you did it. I mean, it's not something you're worried about. You're not really worried about the hypoglycemia with these medicines. It's similar to metformin, and like it's not, and Maggie, you can weigh on too. It's not going to drop you to that. Now, if you're using them in combination with insulin or a sulfonylurea, like you do need to start titrating those. And that's when I would say, hey, you've got a win here. You're going to be weaning off of an insulin or the sulfonylurea class. So, I don't see it being a problem. Maggie, I don't know if your thoughts are on that.
And then one last question. If the patient's losing weight at the low dose, is there any benefit to titrating the dose up or just stay the course on the current dose?
So according to the studies, you are supposed to dose adjust every month, like every 4 weeks going up. And that is how it was. That's how they were studied. But practice is always different than how you do that. So I don't know if I'm allowed to answer that question or if I can give my experience. I just want to make sure I'm not going to like cross any lines, but
I think speaking to the study, and then if Becky Deering, if you want to email back Emily for clinical anecdotes after, that would be a great way to do a follow-up with
and
that.
I would say, like, just to kind of slide into that, I tell my patients your weight loss goal is 2 to 8 pounds a month. And that's because it's recommended like a 0.5 pound to 2 pounds of weight loss per week is a safe and healthy weight loss amount. So that equals 2 to 8 pounds in a month. So what I'll tell them is, hey, message me in a month if you have not lost that amount of weight. And then I make adjustments based on it.
Awesome.